So I'm going to talk about hypercapnia. Now, what you will see there is just I'm going to present some of the data, some of the literature when it's available. When it's not available, is all my sort of what we normally do in our intensive care, what I normally do, and we share it with you. So we'll see what you think. And to do that, we're going to experiment today with, you've got a little pad right on your left side. So there'll be a few questions where you can vote. Is 1 to 5. Now, the thing is, this is not an MCQ for exams. They are not fully right. They are not fully wrong. But it's just to take a temperature of the room and see where we are, and then we can chat. There are a few slides that hopefully we'll discuss together which one might be more convenient. Are we ready? Okay, so let's go next. Sorry. So what I was going to do in the next few minutes is we start looking at the problem of the hypercapnia in the ICU, and then we'll look at cases where some examples of hypercapnia in ARDS, hypercapnia in COPD, asthma, etc. And then we'll talk about a little bit of mechanical ventilation, particularly in COPD and asthma. We'll see why they are so different and why we should consider them very different. And also, eventually, is the sort of the life-saving when hypercapnia becomes a little bit too much and we failed all the previous stops, then we end up to that. But this is not as easy as it seems, and I'm going to talk a little bit about what the pitfalls of extracorporeal CO2 removal, or ECMO, is in hypercapnia. I don't need to go through these, but essentially you'll see that the mechanisms for hypercapnia and COPD and ARDS are sometimes very similar. Hyperventilation, alveolar hyperventilation I'm talking about, more than reduced mean ventilation. Dead space, VQ mismatch and shunt. And then there is this one here, which is a dead space which is functional. In the COPD, we have dead space due to hyperinflation, and that makes sense. The hyperinflation, we squeeze all the capillaries, therefore the ventilation within that lung unit is greater than the pulmonary perfusion. And then here in ARDS, we have dead space due to shunt. Are you familiar with this mechanism? Because if you're not, I've got a very convenient slide I made for you here. So if we think about this is the mixed venous CO2 that goes back into the lung, a proportion of this blood will go through the lung, and a proportion will not go through the lung. This is the shunt fraction. So what will happen is some of the PV CO2 will get removed by the lung, and so the end capillary CO2 will be similar, obviously, to the alveolar CO2. But there is a proportion of the blood, as you all know, that will not go through the lung. And so the two get mixed. And this is the amount of shunted fraction. And so the CO2 is a mix between these two. So if the shunt fraction increases, like the more severe ARDS, the greater the shunt fraction, clearly the amount of shunted blood will go up, the amount of CO2 will go up. So that's hypercapnia due to shunt, okay? Does it make sense? Okay. Are you ready with your little pad? Okay, let's use it. I won't give you too long because otherwise we won't finish. So question 1. So we'll see whether, okay. So we've got a gentleman, 60-year-old, intubated 24 hours ago, has got a PCO2 of 7.5 kilopascal. So the question is, 1, we're not concerned unless the pH is less than 7.1, 7.2, 7.3, that's all right, it's permissive hypercapnia, or this is important, should be addressed. Can we vote? We'll see whether, okay. Have you all voted? Okay. Okay, let's see the results. Very good. So you've got some 7.2 seems to be the top one, but 1 in 5 of you said this is important, should be addressed. Okay, so let's go to the next one. But now this patient, the same patient with the same gas, has got 0.6 of noradrenaline, has got biventricular dysfunction, but lactate is still about 1.4, but it's slightly going up. Same questions again. Let's vote now. What do you think? Okay. Shall we see the results? Okay, this has increased by 11.3%. Obviously, that's very important. And obviously, the criteria, the pH, is still second most common. And I agree, I have to say. So if we go back to that, I think when we think about whether or not we treat the hypercapnia, we need to think about the fight between two opposite strategies. So we need to think, what is the attributable risk of the hypercapnia by itself with the physiology of high CO2 and acidosis, and what is the attributable morbidity that is given by the treatment itself. And today we had already quite a lot of discussion about the stretch, the gentle ventilation, and the respiratory rate, etc. But I think you would agree that over the last, certainly the last 17 to 20 years, or probably longer, actually from the 1980s, we went from a situation where the tidal volume were high, the pressures were high, we're aiming for normocapnia, to protective ventilation, when then we thought permissive hypercapnia was okay, to therapeutic hypercapnia, that actually CO2 is good for you, we should give it to you, you should breathe CO2. And now we are to protective ventilation, to ultra-protective ventilation, just to normalize the CO2. Because probably we recognize the CO2 is not that harmless. And this is a study that was now 10 years ago, 11 years ago. And essentially, when you look at the study that Salvatore has presented earlier on, the 12 versus 6 milliliters per kilo, and you divide patients into hypercapnia and no hypercapnia, you can see that if you ventilate a patient really hard with 12 milliliters per kilogram of ideal body weight, leaving them hypercapnic reduces mortality. Essentially, otherwise you should ventilate them even harder. And here the risk of ventilating them really hard is greater than the hypercapnic. So the mortality is reduced. Well, when you already treat them quite gently, then you can see almost the reverse is true. Having hypercapnia, statistically not significantly, but it will marginally increase mortality. So this is more recent data, I put that for you. This is actually 2 months ago and 4 months ago. Two big study, multi-center, one in Spain, 927 ICU, 40 countries, almost 2,000 patients. And the other one from Australia and New Zealand, 252,000 patients. Okay, so not a small study. And basically what you can see here, that patients with hypercapnia on your left got greater risk of cardiovascular failure, greater ICU mortality, renal failure, and barotrauma, so 11 versus 6%. And this is interesting. Now, I've color-coded that for you, but essentially you start from low to high, blue, green, and brown. That means normocapnia, normal pH, hypercapnia compensated with normal pH, and this is the hypercapnic acidosis. And you don't need any statistics there to say that the greater, so when you go from normal to acidosis, mortality increases, okay, for all groups of PF ratio. And the odds ratio of death is almost 3 times. So if there is an acidosis and an hypercapnia. So this is important. And this is the same thing when you look at adjusted risk for ICU mortality and hospital mortality. You can see there is almost a dose response. It's quite high at low and becomes higher at high. And there seems to be a sort of an ideal point beyond which the mortality increases, which is 65 millimeters of mercury in this study. And this is an old one. You all know that increasing the dead space will increase mortality. So shall we go for another clinical case? This is a little bit more complex, takes some time. But have a look quickly. Don't want you to spend too much time. It has to be instinctive. This is a lady, it's a 68. She comes with an exacerbation of COPD. She's been intubated overnight, and then you, at the handover, someone presents you this piece of paper saying, I've tried 5 different strategies. These are the inspiratory time, the respiratory rate that increases, the tidal volume, PEEP, the total PEEP, plateau and peak. Where do you want me to leave the ventilator? Option 1, 2, 3, 4, or 5. You ready to vote? We'll just have a few seconds, just have a look. Essentially, what I'll guide you through. The inspiratory time goes up, the respiratory rate goes up, the tidal volume varies. This is the PEEP that you add. Start from 0, you go up to 10. This is the total PEEP, plateau, and peak. Okay? Shall we vote now? Let's vote now. I think I can't see that starting. Ah, it's coming. Oh, okay, option 1, option, yeah. Sorry, it's a bit tough, but just to get us familiar with this. Okay. Shall we stop? Okay, let's see what the result. Option 2, I forgot what the option 2 was. I've got it here. So option 2 was, let's have a look. Let's go back to option 2. Thank you very much. So you want an inspiratory time of 0.5, respiratory rate of 20, got a plateau. So it'll be interesting to see that. Okay, keep in mind that, but also keep in mind option 3, which might be my favorite one, but we'll see why. So I'm going to show you a little video of, okay, so essentially, yes, I agree, between 2 and 3, that's great. So I'm going to show you a little video. This was a lady who was lady with severe asthma. And, sorry, let me go back. I'll stop there. Was a lady with severe asthma, very young, was an 18-year-old, very severe, and she was started on extracorporeal ECMO. But essentially, she had no tidal volume whatsoever. She was on 0 PEEP, and she was on very minimal plateau pressure or peak pressure, with the idea to be sort of lung protective. This lady could not get out of the ECMO, and the CO2 was still elevated. So we've done some maneuvers. Don't worry about the ECMO. It's the same thing if they're not in ECMO. So, sorry, let's see whether I can start. And so the first thing, if you see what the background is, the first thing I think is just to go up on your inspiratory pressure until you see a increase in tidal volumes. Then the first thing you want to do, sorry, my finger was, just do an inspiratory pause. Can you see that? Now you've got a plateau pressure there and a peak pressure there. So the difference between peak pressure and plateau pressure divided by the flow is an idea of resistance. So the greater this difference, the greater the resistance for a given. Now, have you seen that plateau pressure? What was it? It was 14, so well below what we would consider safe for a patient. So there is scope for going up on the inspiratory pressure. I think you can go up 22, 25. Now, another way of going up on the tidal volume, you can see now from 99 milliliters, now we got 278. But you can see how spiky this is. This lady is really bronchoconstricted. It's got severe limitation. So the next thing you can do is say, what is the optimal inspiratory time? Because quite clearly, if you increase your inspiratory time, the tidal volume might go up, but at the expense of IE ratio. So you have less time for expiration. So the next thing you want to see is what is the intrinsic PEEP. So you do an expiratory hold at 0 PEEP, and we've seen that the total extrinsic PEEP in this lady is 10. Keep that in mind because we'll see later on whether it increases or decreases. So I'm going now to increase the PEEP because I need to counterbalance that internal PEEP, that intrinsic PEEP. And we'll see what happens. Can't remember what happens next, but we'll see it together, yeah. Okay, so now you can see here there is gas trapping there. Can you see? So now there is some flow at the end of expiration. Flow by time is tidal volume. This is trapped volume. Okay, so I'm going to do another expiratory hold and then check again. And we'll see what it is. Now, let's see. So now it's 11. So now you can see that having added PEEP with this rate and inspiratory time has added to the intrinsic PEEP. So this is not good. Do you agree? Okay, so we need to do something about it. So so what's the next thing we could do? we'll see what I've done, I can't remember. But essentially, one of the things is either your inspiratory time or the rate. So in this case, I've decreased the respiratory rate. But you can see still, this is quite large gas trapping. Do you agree? Yeah? So if you leave this patient for a little while, then the end expiratory lung volume will go up. So we'll see what happens. I try to speed it up as much as possible. That's the time it takes. This is slightly real time, 1.4 times faster. Okay. So you can see now we're going to do the same thing again. Expiratory hold. Oops. Hold. Remember, don't. And now you can see this goes up. Now this is one important technical issue. If you do the expiratory hold too quick, so just before the inspiration, you're going to get a very high intrinsic PEEP. Has to be just before the next breath is due to come in. And now you can see there is not much of intrinsic PEEP. We'll see later on. But you get the idea. I'm not going to run it completely, but I'm going to give you a little circle. So what I'm going to do is just check the peak and the plateau pressure. Just make sure that your peak to plateau pressure is known, so you have an idea of resistance. Optimize the tidal volume using an inspiratory time and the inspiratory time. You do the IP per ZEEP. This is important. Then you start adding some PEEP. And then you maneuver the respiratory rate until you get close to zero end expiratory flow. And then sometimes you need to readjust the respiratory time because you want it just below the maximum. Is it clear so far? Is that helpful, that sort of video? Now, what do you think the respiratory rate of this should be? Now, look at this. This is an asthmatic lady. Flow goes up, flow goes down, really peaked, then goes down this way, and then is flat. It never reaches zero, and it will never reach zero because in asthma, you've got a fixed obstruction of the airways, so this will never reach zero. So if you start respiratory rate here, here, or here, so in terms of you make it faster up to there, you will not change your intrinsic PEEP because the flow is flat. It's only when you make it faster and you get there, that's when you start accumulating volume. Does it make sense? So you can do these maneuvers and check all the time. If you've not increased, you're fine. Now, this is another patient where you can see that at PEEP of very low PEEP, 0, the intrinsic PEEP was 19. This is a patient I would probably not give 15 centimeters of PEEP. These are patients with fixed airway where any level of PEEP above 5 might add to that, so be very careful. So I'm going to do this. This is a COPD, so intrinsic PEEP in COPD where there is airflow limitation, so the small airway will collapse. This is one type of pathology where PEEP might be useful. In near-fatal asthma, there is a fixed resistance. So every time you add to that, you will increase resistance. So that is not useful. And I put that there as an indication. So if you see these brown boxes, this is the intrinsic PEEP of 0. Then you now add some external PEEP. There will be a point where the intrinsic PEEP will go down, but the total PEEP is the same. This is helpful. The problem is when you keep going up, and then now the intrinsic PEEP doesn't go down anymore, but the total PEEP increases, then is when it's damaging. So, okay, and this is in graphical form. You can see the patient number 1, the plateau peak remains the same, despite the fact that the external PEEP has been increased. And here you see that the external PEEP has been increased by the same amount, but the plateau pressure keeps rising. This means that there is hyperinflation. And as we know, the hyperinflation means the lung volume goes up and up and up, and will achieve near total lung capacity, and this is not a great place to be. And if you do a disconnection, we've done it several times, where you put PEEP to 0, let the patient expire completely, long expiration, and then you can see how much volume was trapped in the chest. And this is important because if you look at the ratio between the greater the intrinsic PEEP, the greater will be the amount of volume that is trapped in the chest. And the volume that is trapped in the chest is what causes barotrauma, hemodynamic instability. Okay, so much more important. There is this ratio 1.4 or 20 mils per kilo that has been shown in the literature to be the real cut-off point. I think it's the last quiz, if you don't mind. Fingers ready. So this is a lady, 48. She's a smoker. Okay, new diagnosis of asthma, intubated 8 hours ago with a size 7 tube. Oh, okay, I can see the face. What do you think of this? Well, quite severe gas trapping, you can see on the end tidal and on the flow. So the question is, question 4, this is what you see, gas 1, PO2 of 9, PCO2 of 9, PO2 of 10, this is what you see, a PEEP 0. What would you do first? Shall we vote? As I said, there's nothing wrong or right, it's just to see what people think. Unfortunately, we don't have multiple. You can borrow your neighbor and then. Yeah. Well, there will be more than one, absolutely right, yeah. Yes, okay, fine. Okay, enough time? Okay, let's see the results. Okay, so yeah, tube change, increased TI, yeah, to see whether you can get more tidal volume and increase PEEP. Yeah, that's I think. But you've done something, not quite clear what it is, and now this is what you get 2 hours later. So now the CO2 has gone up from 9 to 10.5. The PO2 has gone down. Tidal volume hasn't really changed. I think you've increased the PEEP. But the plateau has gone from 15 to 22. So this is not a good sign, as we've seen. And the peak pressure now is 37 to 44. So this indicates high resistance. You have not modified the intrinsic PEEP. Plateau has gone up, tidal volume has gone down, and the gas exchange is worse. But you've got new options now. So what are we going to do next? I feel like university challenge. Okay. Are we all voted? We just tried to minimize. Okay, so let's see the results. We'll see where we are. Okay, so go back to PEEP of 0. Still increase the TI. Yeah, we don't. It's very difficult. I've been unfair here because I've not given you the TI. So, but some people would do 1 in 5 almost would do some echo-to-R and others in ECMO. So I'm going to tell you what happened to this lady. This is what happened. So I think the 18% who voted ECMO, I think eventually was right, but there's no way of knowing. You can see there's a big cannula there, jugular, and there is a access cannula in the femoral vein, completely white. And this is interesting. What do you think of this hemodynamic profile? Sorry? Yeah, there's a huge stroke volume variation, which in the context of asthma is a pulsus paradoxus. So she's got almost 40 millimeter of mercury, a pulsus paradoxus. She cannot breathe spontaneously. This lady will need to be obviously sedated. And this is, I've shortened the scale for you. You can see massive amount at the end of inspiration of the change in stroke volume. Okay, so this is a problem. And then, obviously, bronchoscopy. We love bronchoscopies, don't we? Yes. And this is what come out. Casts. Okay, this cannot be solved with a TI increase, with a PEEP increase or decrease. These essentially, they're plugs. And you remove it, and remove it, and remove it. And 6 days later, she's perfect. Okay. Now, let's see for the COPD instead. We've got a gentleman, he's 65, it's Thursday, and it's 8 o'clock. It's always Thursday or Friday late, isn't it? And then it's got severe COPD, we know that. Comes with a CO2 of 12. Failed a non-invasive ventilation in A&E, doesn't want to be intubated, but at the same time doesn't want to die. So it's a situation that we've got there at the moment. And so echo-to-R, sorry? Topical oxygen, cream, yes. So what we have done before the topical option, we went for an endovascular option. So this is an echo 2R, the same thing like ECMO, but just miniaturized. It's a single cannula coaxial double lumen, and takes blood out, very low pump flow, oxygenates, takes some CO2 out, reinfuses. Okay. This is as much as I'm going to say about the echo 2R, and I think I'm not going to review the literature for you, with you, but I think we need to agree on 3 points. We need to agree the extracorporeal CO2 removal removes CO2, okay? We agree with that? We agree that it's less invasive than ECMO, and we agree that there have been observational propensity matching studies that have shown efficacy. And we also agree what we want to achieve with that. We want, in ARDS, we want to reduce transpulmonary pressure, we want to reduce driving pressure, but we have no control on the CO2, limited. We have little or no control on oxygenation that we can give. And you can see that in COPD. Certainly we want to avoid intubation if we can. We want early extubation, plus or minus non-invasive ventilation. We want to reduce the work of breathing and the massive change in transpulmonary pressure as we've seen in that lady with asthma. And same thing with the asthma. He's happy so far, but we've got problems with CO2. Okay, so he's a brilliant machine, but I'd like to make 3 points. One, we've got problem with the PF ratio. We'll see how. We've got to limit how much CO2 we can remove. And also we need to be conscious of the effect that extracorporeal CO2 removal has on the native lung, the lung. Okay? So this is a group of 12 patients, okay, in our ICU on your left-hand side. Now what you can see is brilliant. So you start the extracorporeal CO2 removal. The respiratory rate, this is all acute patients, goes from 42 average down within 4 hours to 20. Patients feels much, much better. The work of breathing is gone to less than half, and then it stays roughly the same. The pH goes up, and it's great. But what happened here, so if you're expecting a massive reduction in CO2, probably you're not going to find it. And the reason for that is that the CO2 removal has taken half of the work, or more than half of the work of the patient, to remove the same amount of CO2. So the CO2 roughly goes down and remains the same, but the patient feels better. But the CO2 is not full. Okay, this is important. And if you increase the gas flow from 0 to 10, you reach a ceiling point, about 4 to 5 liters, where the CO2 removal becomes flat after that, because there's not enough blood to decarboxylate. And that's important. But this is a very busy slide, but I want to show you something. In this trial here, which was published last year, the CO2 removal was 81 milliliter per minute. Now, normally we produce 250 to 300 milliliters per minute of CO2. So you can see, although it's not a lot, it's substantial to make the patient feel much more comfortable. But the CO2 remains roughly the same. Starts at 51, ends up at 55, 41. But there is a transfer of work of breathing. Now, the PF ratio, normal, after 2 liters of gas flow, goes right down almost into the severe category of ARDS. So PF ratio about 17. So this is important because as a patient with COPD has a great oxygenation need, then you be prepared that you might need to increase the FiO2. How are we doing for time? Sorry.
All right, got about 15 minutes.
Oh, brilliant. Okay, so I'm going to show you this. It is my attempt to arrive to this point where the battery is empty and there is a decrease in oxygen, PaO2. So let's follow it from the beginning, okay? So I'm going to guide you on your left-hand side first and then on your right-hand side. So if you stay with me. CO2 removal, the first thing we said is that because decreases the CO2 in the mixed venous blood will reduce the tidal volume and the respiratory rate. We've seen it earlier on. And as a consequence of that, if the patient is ventilated, the mean airway pressure goes down. Okay, if the mean airway pressure goes down, there might be some lung de-recruitment, okay, which might lead to PaO2 reduction. Otherwise, the reduction in venous CO2 causes a reduction of the amount of CO2 that goes to the alveoli. Just follow me 1 second, see whether I've managed to explain it. And because we know that the CO2, it goes into that little equation of the alveolar gases, where there is a little r, which is the VCO2 divided by the VO2. In other words, the lower is the CO2 that goes into the alveoli or perfuses the alveoli, the higher is the respiratory quotient. Therefore, the lower is the pressure of oxygen in the alveoli. As a consequence, for the same FiO2, the PaO2 is down. Okay, so this is important. Let's go down on the other side. Now, when we give sort of gas flow with the extracorporeal CO2, we give 100% oxygen. So the amount of oxygen that is in the mixed venous goes up. Now, if there was hypoxic vasoconstriction in patient with COPD, which is used to preserve the ventilation perfusion ratio, this is completely abolished. And if this is abolished, the functional shunt increases, and as a consequence, you've got a decrease in PaO2. So worker breathing, great. CO2 perhaps depends on the patient, and just be careful about the PaO2. And in this study, for example, a certain number of patients, once they've been started on extracorporeal CO2 removal, had to be proned, and some of them had to be started on ECMO. So the change in PaO2 can be dramatic depending on the pathology and depending on your starting shunt fraction. So I'm going to summarize, and this is my last slide. So I think about the consequence of hypercapnia. You need to balance in your mind the cost of hypercapnia itself, so high CO2, versus the cost and the morbidity that is associated with the mechanical power or stress and all the extracorporeal support. Nothing comes for free, but you need to choose the least damaging option. Just have a method to go through systematically in terms of mechanical ventilation, maybe something consistent within the unit. Monitor the IPEEP and think that dynamic hyperinflation, so the amount of volume that is left at the end of expiration, rather than just the IPEEP, is what causes the barotrauma. And then, if you think about the three main pathologies that can give you hypercapnia, dashed line are the ones least preferred options, and the continuous lines are preferred option. So COPD, echo 2R, possibly non-ECMO, not ECMO. ARDS, this is to be trialed. There are 2 trials at the moment, multinational, the REST trial and the Supernova, that will test this hypothesis. So at the moment, we can't know for sure. And asthma, I'm not sure whether I would do CO2 removal and think about ECMO. And with that, I thank you for your attention.